Welcome to Drugs in Dermatology. In this video, we will be discussing one of the most important advances in dermatology, the anti-interleukin-4, interleukin-13 class of biologic therapies. In other words, it's a video on dupilumab. This class has fundamentally transformed how we approach type 2 inflammatory skin diseases. Although there are biologics for interleukin-13 exclusively, such as tralokinumab and lebrikizumab, we will talk about those in a separate video. An important note is although this class of drugs may be utilized for a wide range of treatments, we will be looking through a dermatology lens focusing on dermatological diseases that are FDA approved. So, let's break it down. Drugs in dermatology style. Dupilumab is marketed under the brand name Dupixent and co-developed by Regeneron and Sanofi. It is a fully human monoclonal IgG4 antibody administered subcutaneously. It targets the interleukin-4 receptor alpha subunit, which is the shared receptor component for both interleukin-4 and interleukin-13 signaling. By binding to the single subunit, dupilumab simultaneously inhibits both of these central type 2 cytokines. Dupilumab holds the historic distinction of being the first biologic ever approved for atopic dermatitis, and it has since expanded to cover several other type 2 inflammatory conditions of the skin. The American Academy of Dermatology identifies dupilumab as a first-line systemic agent for moderate to severe atopic dermatitis in adults, and it has a well-established safety track record over more than 5 years of continuous clinical use. The development of dupilumab was grounded in the recognition that type 2 inflammation, which is primarily driven by interleukin-4 and interleukin-13, was central to the pathogenesis of atopic dermatitis and other associated inflammatory conditions. Regeneron and Sanofi co-developed dupilumab to precisely target this immune axis. In March 2017, dupilumab received its first FDA approval for moderate to severe atopic dermatitis in adults. This marked when it became the first biologic therapy ever approved for atopic dermatitis. In March 2019, the indication was expanded to adolescents aged 12 years and older with moderate to severe atopic dermatitis. In May 2020, the approval extended further to children aged 6 to 11 years, and in June 2022, infants and children as young as 6 months of age were included. In September 2022, dupilumab received approval for prurigo nodularis in adults, first FDA-approved treatment specifically for this condition. Most recently, between 2024 and 2025, additional approvals were granted for chronic spontaneous urticaria in patients aged 12 and older, and for bullous pemphigoid in adult patients. Dupilumab currently holds FDA approval for 4 dermatologic conditions. First, atopic dermatitis, approved for moderate to severe disease in patients aged 6 months and older, and can be used with or without topical corticosteroids. Second, prurigo nodularis, approved for adult patients. Prior to this approval, there was no FDA-approved systemic therapy specifically indicated for this condition. Third, chronic spontaneous urticaria, for patients aged 12 years and older. And fourth, bullous pemphigoid, for adult patients. Knowing the mechanism allows us to explain why dupilumab works so well, why it produces some of its unique adverse effects, and what potential future uses may be. Interleukin-4 and interleukin-13 are the principal effector cytokines of the Th2 immune axis. Interleukin-4 signals through 2 receptor complexes: the type 1 receptor, which consists of the interleukin-4 receptor alpha subunit paired with a common gamma chain, and the type 2 receptor, which consists of interleukin-4 receptor alpha paired with interleukin-13 receptor alpha 1. Interleukin-13 signals exclusively through this type 2 receptor complex. dupilumab binds specifically to the interleukin-4 receptor alpha subunit. Because this subunit is shared by both receptor complexes, a single antibody simultaneously blocks all interleukin-4 signaling via the type 1 receptor and both interleukin-4 and interleukin-13 signaling via the type 2 receptor. The downstream effects of this dual blockade are significant. In multiple cell types, including mast cells, basophils, eosinophils, lymphocytes, and epithelial cells, dupilumab reduces the release of pro-inflammatory cytokines, chemokines, and IgE. In the skin specifically, dupilumab suppresses type 2 inflammatory gene expression, including interleukin-13, interleukin-31, CCL17, and CCL18, reduces epidermal hyperplasia, and restores expression of essential barrier and differentiation genes such as flagrin. This directly addresses the fundamental skin barrier dysfunction that underlies atopic dermatitis and other type 2 inflammatory dermatoses. This drug class carries an overall favorable safety profile, especially when compared to conventional systemic immunosuppressants such as cyclosporin or methotrexate. However, there are several adverse effects that you should know well. The most common adverse effect is injection site reaction. Conjunctivitis and keratitis is a well-recognized clinically important adverse effect, and further evaluation should be considered in symptomatic patients. Nasopharyngitis and upper respiratory infections, herpes simplex virus infections, and headache are also commonly reported in clinical trials. An interesting adverse effect, relatively unique to dupilumab, is dupilumab-associated head and neck dermatitis. This is a distinct rash affecting the face and neck. The hypothesized mechanism involves exacerbated Th17 and Th22 immune responses that emerge as the Th2 pathway is being suppressed. Less common but notable adverse effects include new-onset psoriasis, alopecia areata, and hypereosinophilia. Paradoxical inflammatory reactions are thought to arise because Th2 pathway inhibition may unmask or exacerbate Th1 and Th17 dependent immune responses. The sole contraindication for dupilumab is known hypersensitivity to dupilumab or any of its excipients. While serious hypersensitivity reactions are rare, reported reactions have included anaphylaxis, AGEP, serum sickness, angioedema, and erythema multiforme. Any clinically significant hypersensitivity reaction warrants immediate discontinuation of the drug. As always, we will close with the table going over the main talking points of this video. I hope you have a better understanding of anti-interleukin-4 and interleukin-13 therapies. This is meant for educational and informational purposes only, and should not be used as a substitute for medical advice, diagnosis, or treatment. Thank you for watching, and see you in the next video.